In this audio lecture, we're going to be talking about metabolic alkalosis. So, just like the name would suggest, that we are dealing with a metabolic originating disorder and is resulting in alkalotic condition, right? So an increase in pH. Alright, so metabolic alkalosis, it is either an increase in bicarbonate levels, and that would increase pH directly, right? So, or a decrease in hydrogen ions. Right? And so traditionally we're going to see an increase, so we will see an increase in pH, we will see this increase in bicarbonate concentration and decrease in hydrogen concentration. And then we're going to see really this elevation in bicarbonate levels in circulation. So metabolic alkalosis can be caused from loss of fixed acids, so those would be the volatile acids, right? Specifically when we lose stomach acids through vomiting, right? So we're going to be losing hydrochloric acid, okay? And if you remove that hydrochloric acid, then it's got to produce more hydrochloric acid. So this results in bicarbonate moving in to replace the chloride that is left, that you don't have to make that new hydrochloric acid. So when gastric secretions are lost, they'll contain hydrochloric acid. Okay? The stomach's response to that is to replace the hydrochloric acid. Right? So it has a plentiful supply of hydrogen, right? But it grabs all these bicarbonate that are in the plasma and put them into the stomach. Okay, and so that results in you starting mechanisms in the kidneys to reabsorb more bicarbonate. So now we have this alkalosis from that mechanism. Now, very rarely is excess base going to be a problem. The only problems that can really present an issue when you have too much bicarbonate intake, really. Okay, so this can be due to antacids or intravenous sodium hydroxide, sodium carbonate IVs. Okay, so specifically, there's one condition with it's called milk alkali syndrome, and it's when people take their antacids and then they drink it with milk, right? And so the antacids will promote the formation of bicarbonate, no breakdown, okay? And then hypercalcemia prevents urinary excretion of that bicarbonate, okay? So not only like we're really trying to bump up the bicarbonate levels if we use this mechanism. So don't do that. It could result in metabolic alkalosis. Okay. So some other causes can be losing chloride in urine, right, which would suggest that the bicarbonate chloride exchangers, that mechanism that is often used to uptake bicarbonate, is overutilized at this point, and so we end up having additional chloride loss in the urine, but we're getting increased bicarbonate reabsorption as well. Okay. Then the transcellular shifts. So remember, the transcellular shifts moved hydrogen and potassium around during base and depending on the base and acid change. Okay. So in hypokalemia, okay, we see that in the ICF you get potassium leaving, okay, to increase this potassium concentration, and in response to that, we're losing these hydrogen levels, or these hydrogen ions that are going in place of it to keep it electrically neutral. Okay. We can see that a use of medical devices, okay, like artificial ventilation, if that corrects respiratory acidosis too quickly, okay, if PCO2 is corrected too quickly, as is the case in mechanical ventilation, renal compensatory mechanisms that have been started, okay, can overshoot what the original problem was. And so here we have decreased ventilation, yep, and over here we have decreased excretion of hydrogen, okay, and decreased reabsorption of bicarbonate, both of which would decrease the pH. Okay, so normally this is going to manifest itself as a dehydrated or hypokalemic state. Okay, It's going to result in various neurological problems, including confusion, hyperactive reflexes, tetany, carpopedal spasm. Okay. So the compensatory hypoventilation, okay, where we're going to be slowing down ventilation rate, is that'll be another way this kind of displays itself. Okay. And then if it's too severe, if metabolic alkalosis sits in too severe, then what we have is we get pretty morbid outcomes here: respiratory failure, cardiac arrhythmias, seizure, coma. All right, so in diagnosing metabolic alkalosis, we're going to be taking a patient history and physical examination. We're going to be looking for any manifestations that we just talked about. Our arterial blood gases, we're going to take a measurement there, and then blood chemistry. Right? So blood chemistry is going to tell us that we are alkalotic in origin, and then it's going to tell us that probably bicarbonate levels are increasing. Right? So they are going to be above really 26 millimeters, or not millimeters. They will be above 26 milli equivalents per liter. And then we're also going to be running a complete blood count as well. So you would treat metabolic alkalosis by treating the underlying cause, like is in most of these things. Okay, so addressing the chlorine, chloride, and potassium deficits. Okay? So chloride will replace any bicarbonate in gastric solutions. So if the case was due to vomiting, okay, and the loss of chloride ends up pulling bicarbonate out of circulation, then what we can get is a replacement with potassium chloride. Here will send that bicarbonate back to where it needs to go. Okay? And then hydrogen would be retained in addition if the bicarbonate was allowed to kind of go where it should.